Is that okay? Do you need me to say anything for testing?
Hi, Greta. Are you there?
Yep, I'm here.
Oh, now I can hear you.
Okay, so should I continue on? Is okay?
Yeah, please continue.
Okay, so yeah, anyone can go to the website www.parkinsons.ca or the Parkinson's Clinical Guidelines.ca, and you'll be able to download this full document. It outlines what's the current treatment guideline for Parkinson's disease, and my talk will be based on this information. And this is the wonderful group of people we're working together to look at all the evidence and put together this guideline. And I learned a lot from this process. So from the guideline, we understand the diagnosis of Parkinson's disease. First, when someone suspects some symptoms, initially is the slowness of movement. And if there's additional like tremor or stiffness, then that's more confirming some Parkinsonian type of symptom. But the doctor still have to observe and also see the response from treatment to have a firm diagnosis of Parkinson's disease. So when you get the diagnosis, it's important to have better communication to understand exactly what's going on. And also it's important to have a balance between the realistic information and also to keep the optimism in terms of, what's going on in the future, what's available. So as I mentioned, the diagnosis of Parkinson's disease is purely based on neurological assessment, slowness of movement, plus tremor or stiffness. So even though we know Parkinson's disease is a progressive condition without a cure, but keep in mind there's a lot of exciting research going on, especially with the stem cell research. And also in the future, there will be like inhaled levodopa for a quick solution for that sudden wearing off. And also new treatment available right now, including sulfonamide and also the duodopa gel infusion by the J-tube. So in US right now, they have this extended release levodopa. Is not yet available in Canada. So hopefully we'll see that in the future. So this is a really slow, long-acting levodopa. So people don't have to take levodopa as frequently. And also, as I mentioned, the inhaled levodopa is currently under clinical trial. So it works within 10 minutes and the effects will last for about an hour. So for someone have those unexpected sudden off. And don't forget, exercise. Early on in the journey, it's important to exercise. And no matter what stage of the disease, having exercise really maintain your function. And patients can keep the medication dose low by actively involved with exercise. So we see that in our patients, someone who has Parkinson's for over 10 years, but they keep exercising and they're doing so much better. And in terms of vitamins, in the past, there's a lot of talk about vitamin E and coenzyme Q10, but in research, we really don't see any good evidence. So we don't suggest people spend money buying these vitamin E or coenzyme Q10. On the other hand, vitamin D is very important because more studies showing people with Parkinson's have vitamin D deficiency, and also vitamin D is known for many different conditions and also to strengthen bones. Vitamin B12 is crucial, especially if someone's vegetarian, because it's good for the brain function, especially when it comes to memory. So make sure you don't have vitamin B12 deficiency. And patient may find vitamin B complex is helpful for energy. So that also includes vitamin B12 as well. So for people who have a tendency to yell or kicking during the sleep because of very vivid dreams, melatonin actually is quite helpful. The one we usually recommend is the time release tablet, so that through the night, the benefit will be there to help patient to sleep better, more deeper level of sleep, and have better energy during the day. And of course, if you're losing weight, it's important to have nutritional supplement, because as we lose weight, we weaken our immune system and also affects our strength. So I'll be going through a few cases and using these fictitious cases to illustrate how we apply the guideline and when do we use different medication. So bear in mind, each patient is different. Our presentation of symptoms will be different, and plus our other medical conditions different at different stage of the disease. So it's hard to compare, my symptom and my treatment versus your treatment. Okay, so let's start with the first patient. So someone's young, like John, 55 years old, financial consultant. His initial symptom was tremor in the right hand for about 2 years, and he started to find difficulty using the computer. His wife noticed his steps smaller, and also the walking speed is slower with occasional shuffling. So he worries that he can no longer work. So as we know, with the diagnosis of Parkinson's disease, there's concern that our brain is no longer producing enough dopamine. So let's go back to the picture. Dopamine is, we call it the brain chemical, neurotransmitter. We need this chemical to pass on message from one brain cell to another. So when there is deficiency of dopamine, the whole communication is broken down. So that affects our coordination, affects our speed, moving, and functions. So with the Canadian guideline, it actually encouraged people to consider medication earlier. There's a tendency of fear of using medications, fear of side effects, but in fact, there's more evidence showing if patients getting treatment earlier and start exercising, then we can actually keep the dose low. And also there's another good argument is treatment initiated earlier rather than later may spare the those brain cells that specialize in making dopamine. So when to start treatment depends on the symptom severity, whether the symptoms affect the dominant hand. Say if you write with your right hand and your symptoms affecting more the right hand, then there's a consideration. And also, is the person working or a person is retired? Does it affect your hobbies or activities? And what about cost of the medication? Because some are covered by Ontario Drug Plan, or the individual may have a private drug plan. And patient's preference based on benefit versus risk. So we have 3 classes of medications for initial treatment. The first one is monoamine oxidase B inhibitors. So this is the group of medication that retain dopamine in the brain by preventing dopamine being broken down. So this is the group of medication is the least potent, but it has some benefit or being studied in the past for resergyline. So this one is a newer MAO-B inhibitor, and one of the studies called Adagio study, and they found when patients start on resergyline 9 months earlier, seem to maintain the benefit that for patients who start late is not able to catch up. So even though the study seems to work for 1 milligram daily dose, they found with the higher dose doesn't have the same kind of benefit. So that's why it's not marketed for delaying progression of Parkinson's. But some people like to use this medication, even though it's the least potent, just hoping that if it has some benefit, I want to give it a try. So Resergyline is once a day dosing, and Selegiline is older medication and is in the same category, but it has tendency, it has the transformation to amphetamine. So that's why people, when they take Selegiline at night, they may have trouble sleeping. So most of the time, patients start with Resergyline if they want to use this group of medication. So Resergyline require private drug plan. So it's about $7 a day. And the other group of medication is levodopa. This is the only medication become dopamine in the brain, and it's the most effective. And it comes in a combination of levodopa, carbidopa, or prolopa that has been sericide as the second ingredient. So the reason why we have the second ingredient is to allow more of these medication get to the brain before it get converted to dopamine in our peripheral blood circulation. So without the second ingredient, we have more side effects such as dizziness or nausea. So it's great to have the second ingredient so that we get more benefit of the medication. So one of the concerns for levodopa is may have a shorter duration of benefit for each dose because levodopa doesn't stay in our body very long. So when it comes to consideration of choosing which medication, some patient may consider using other medication first. But again, this is the person's preference. And for a young patient like John, he's only 55 years old, the tendency of getting dyskinesia, which is the involuntary body movement, tend to be more common in younger individuals. So it may affect the body movement and the limbs. So with levodopa, it has a tendency to cause a little bit more dyskinesia, especially when the dose is high. So it's important to keep the dose of levodopa as low as possible to minimize the risk of dyskinesia for someone who's young. So someone asked, like, why does it happen? Why is the body's kind of moving like this? It's mainly because of the dopamine receptor becomes so deprived of dopamine. So when we have levodopa treatment that becomes dopamine, suddenly it have exaggerated response. So the body is moving a little too much. But interestingly, when we ask patients who actually experience dyskinesia, they actually don't seem to have concern about it because they would actually feel better when they're able to move, even with a little bit of involuntary body movement. They found they're not too concerned. So if you look at group 3, these are the patients, they have experienced dyskinesia, but when you ask them if they're very concerned, they actually don't seem to be very concerned. So you see the burgundy line, they're only mildly concerned about dyskinesia. So the bottom line is with dyskinesia, especially for someone who's older in terms of like closer to the age of 70, that should be less of a concern for people who want to choose levodopa. Okay, the third group of medication is dopamine agonist. This is the type of medication just mimic dopamine. It does not become dopamine themselves. So the three common ones are pramipexole, ropinirole, and the patch, the rotigotine patch. So younger patients tend to consider dopamine agonist because it may have less fluctuation in terms of wearing off and the dyskinesia. But because this group of medication is not as effective as levodopa, so patients eventually have to start using levodopa. So is there any side effect associated with dopamine agonist? The answer is yes. That's the drawback of dopamine agonists. It tends to cause more dizziness, ankle swelling, and for elderly patients, we actually don't recommend dopamine agonists. In the guideline, it mentioned for individual older than the age of 70, we should use this group of medication with caution, if not avoid it, mainly because it tends to cause more hallucination and confusion. And as we get older, we have higher risk to experience confusion and dementia. So that's why this group of medication is not for or not recommended for someone older than 70 years old. And in terms of other side effects, drowsiness or this concern of sudden sleep. So the advice for someone who want to start this medication, initially the first few days is better not to drive until they totally understand or feel how the medications would affect your body function. The other one I want to mention is the risk of obsessive behaviors. That means there's certain behavior that's new or they seem to lose control of it. It could be eating, shopping, gambling, or even watching pornography or experiencing hypersexuality. So this is considered as the compulsive or impulsive control disorder. So there is a questionnaire that we always ask patients before and after starting dopamine agonist. In the last few weeks, do you feel a strong desire to gamble or more desire for sex, shopping, eating, or even hobby? Hobby in terms of playing computer game or going on the iPad, constantly on the iPad. And I remember one of my patients, he loves to go fishing. So we thought, oh, okay, great. So the wife would go with him, go fishing every weekend. But I start to worry when the wife tell me that he get frustrated when she doesn't want to go with him one day. He still insists to go. And even when it's like pouring rain and we're very cold out, consistently, like he will have to go every weekend. So this is a little bit concerning. And then, well, as we dig deeper, indeed, like he starting to have more compulsive desire for fishing after he starts on dopamine agonist. So it's important to explain the risk of this type of behavior before starting medication, and also have family member to watch over the patient to make sure the symptoms is not beyond control. So the impulse control disorder can develop at any stage, and especially for those taking dopamine agonists. Now, the last group of medication is called anticholinergics. This is a very old type of medication. It's only useful for tremor, and it has a lot of side effects. Actually, just as complex as the dopamine agonist, they can also cause hallucination, confusion, affecting memory, causing drowsiness, blurred vision, dry mouth, that affects swallowing, and also trouble urinating and constipation. So definitely is not recommended for elderly. And we only try to use it if really necessary when the tremor is really prominent and for younger individual. Now we'll go back to John. So he's young, he's complaining about tremor, affecting his function, and his walking is being affected as well. So we lay out this option for him because his symptoms seems to be um, a little bit affecting his function and work. So he feels resergilin may be not strong enough. So he chose option 2. So he want to try dopamine agonist, and we want to monitor the side effect because he has a lot of worry about the dyskinesia, and he just want to try dopamine agonist first before trying levodopa. So it's really the personal choice. So he actually chose the patch because it seemed easy to use. Just put the patch on every day. We told him to start with 2 milligrams and slowly titrate up the dose. And we told him about all the side effects and also went through all the information with his spouse so that she'll watch over any impulsive behavior as well. And also initially, the first couple of days, not to drive until he makes sure he's not too drowsy. And he's also reminded to rotate the site. When he put the patch on, he need to change to a different location, not to use the same spot for 2 weeks because the patch can irritate the skin. In order for the patch to stay on, you need to put your palm, put it on top of the patch so the body heat can keep the patch to stay on the skin longer. So it's a little different from the bandage that we usually use. So this one requires a little bit of warm body heat to leave the patch to stay on better. For him, because he has to see clients and he really doesn't want that hand trimmer bothers him too much. So we want him like only if necessary, he may use a small dose of anticholinergic, in this case, the trihexyphenidyl for severe tremor only if he need it. So we ask him to watch out urination and constipation. So regarding the patch, for patients who have sulfite allergy, uh, they may have higher risk for allergic reaction, even hives or rash. So people with severe or documented sulfite allergy, the patch is not suitable for them. So luckily, John doesn't have sulfite allergy, so he doesn't need to worry. He also Googled and tried to find different gadgets. So he actually found the Google spoon and also the specialized glove that recently developed at U of T. So we tried these gadgets to minimize the need of the anticholinergic medication. So he's doing well in terms of Parkinson's, but the wife also reported he still have trouble sleeping, poor appetite, and he worries a lot. That actually affects him more than the Parkinson's. So we did some assessment. So from the Hamilton Anxiety Scale, it's a whole bunch of questions that he would answer, like how anxious he is and how much it affects him. So actually, he scored fairly high, so indicates he is quite anxious, and to the point that it affects his sleep, so he doesn't have energy to join any support group or exercise. And he's open to try a little bit of medication to reduce anxiety. So we recommended mirtazapine. It's just a quarter of a tablet. He can take it at night, help him sleep, and get better energy during the day. We also encourage him to go to this website. It's called the Bounce Back. It's a cognitive behavioral therapy through the video. And if you search bounceBackOntario.ca, and then you'll find a whole bunch of video in different languages. And this is quite helpful because we don't want to just use medication, but cognitive behavioral therapy is known to be beneficial. And just want to introduce to everybody, this is a very useful guide. It's called Guide to Non-Motor Symptoms. So remember, Parkinson's is not just affecting our physical symptoms. There's a lot of non-physical symptoms, including anxiety or poor sleep that John experienced. So it's a good reference to have. So you can go online and download this reference. So don't forget, exercise is so important. And also the more education you have about the disease, you feel more empowered, you know what to do, and you feel positive. And there's a lot of research showing Tai Chi or exercise with the Nordic pole that will help to train your coordination. Fall prevention education is very helpful, and exercise also find to increase the brain-derived neurotropic factor that protects the brain, and also showing likelihood to delay Parkinson's progression. So exercise is all good. So from our guideline, it mentioned levodopa is effective medication and can be used early. So we really don't have to wait. We don't have to try dopamine agonist first. Okay, so levodopa can be used early, and by doing more exercise, you can keep the dose low. And patient with possible diagnosis of Parkinson's, like for John, who's younger, would benefit a trial of dopamine agonist. And again, the impulse control disorder need to be monitored. Okay, and our second patient is Sandy. Sandy is a bit older. She's 78 years old, retired high school teacher. She has some concern with her memory, but overall she's doing well. She's still living alone at home. She has some right arm pain with muscle stiffness, and she noticed her balance is not as good with shuffling gait. Um, Unfortunately, she had one fall last month when she walked and tripped over the carpet. And she noticed that a lot because her right leg tends to feel heavy. So for Sandy, what option would be suitable for her? So again, she can have levodopa or the MAO-B inhibitors such as rasagiline, selegiline. Would you pick dopamine agonist? For Sandy, we won't because she is older and she already has some concern. Her memory is not as good, so we stay away from dopamine agonists. We also tend to choose levodopa because her symptoms is affecting her to the level she actually had one fall. So we'll show her some gait strategy, how to walk with heel first to prevent tripping over, and also remove any loose carpet in the house to make sure the home environment is safe. And in her case, again, the rasagiline may not be suitable because her symptoms is affecting her day-to-day function. So what can we do about memory? If it's mild, again, it's important to engage in some cognitive or social activities. So make sure you're not stuck in the house. Go out and join some community programs. There's tons of programs for seniors, whether it is for hobby or social dining, book club, card, all kinds of hobbies. So it's good to be involved in a social environment because there's a lot of studies showing social activities and exercise can delay or prevent the dementia from occurring. Okay, our other patient is Joe. Joe is 68 years old with Parkinson's for about 8 years. Now, when I talk about the years of Parkinson's, again, everybody's different. So if I have Parkinson's for 8 years, I may be taking pills more frequently. So everyone's different. So Joe is taking levodopa, carbidopa, 2 pills 4 times a day. He also takes the control release at night. And one day he was so worried because when he got up in the morning, by noontime, he realized he's not able to move. He was so stiff, and he asked like if something wrong, should he go to emerge? So I looked at his list of medication. He's taking the levodopa, carbidopa like at 8, 12, 4, and 8, like every 4 hours. The only change for him is that morning he woke up late and he took his first dose at 10 a.m. instead of 8 a.m. But because he woke up late, so he's so hungry, so he had a full breakfast at the same time instead of waiting for that 1 hour gap. So he took the pill. The pill doesn't seem to work. So he was stiff for over 2 hours. In addition to getting up late and had late breakfast, he normally also experienced bloating, indigestion, also have constipations frequently. So when we asked him like how's his stool usually look like, he mentioned usually like type 1 or 2. That indicates the stool been in the colon for a long time, they're dry, and that means the stool is not moving through the colon fast, and also indicates the motility of the bowel is very slow. We always remind our patient that your stomach connect to the small bowel and connect to the colon, so everything essentially is one tube. So if someone's constipated, your small bowel likely is not moving. So it's important to know that levodopa is absorbed in the small bowel, not in the stomach. So we need to get the pill to get down from the stomach to the small bowel quickly so it can be absorbed quickly and to work fast. So what happened with Joe? He had the full breakfast, even though he took the pill first, but he immediately had a full breakfast. And he also had eggs, and that eggs contain protein. So protein has the chemical structure that's very similar to levodopa. And our body require a special transporter to bring the levodopa or the amino acid, the protein, across the small bowel and also to our brain. So if you have protein at the same time, then it will saturate all these transporter. So the transporter will have to decide, should I carry the protein or should I carry the levodopa through the small bowel to the brain? So you're delaying the process of absorption if you have a full meal, especially with protein at the same time. So if there's food in the stomach, it's almost like created traffic jam. It takes a long time for the levodopa to get through the food in order to get to the small bowel. So remember, the pill is absorbed in the small bowel. So he already have constipation and also very slow GI movement. So that's why the pill is very slowly getting through the system. So as I mentioned, he had the full breakfast and protein, so that explains why the 10 o'clock dose is not working. So we assure him being off is only temporary. So take some deep breathing, relax, and the pill will eventually work. So resist the temptation of taking additional dose because he already just took a dose at 10 a.m. So by 12 noon, we just ask him to crush the 12 noon dose. And if he wants, he can mix in a small amount of pop so the pill will work faster. So by 1:30, he's finally feeling back to normal. So in terms of constipation, which is very common with people with Parkinson's, and check what you also take, because some medication can worsen constipation. We know amantadine can worsen constipation, and so is calcium carbonate. So if that's the case, then it makes sense to switch over the calcium citrate. It's more easily absorbed, or just have calcium in your diet from your yogurt, cheese, or milk, rather than taking calcium carbonate tablets. Of course, like exercise, drinking lots of fluid, having some fiber is good, but don't have tons of fiber, because if your GI tract is not moving, you load it with a lot of fiber, you may also causing a bit of congestion. So it's more useful to have medication like lactulose or restore laxative, because these actually bring the fluid that you drink to the colon to soften up the stool. And if you still have no regular bowel movement, you may need to add the Senokot, because Senokot is a stimulant that will push the stool out. When it comes to Restore-Lax or Laxaday, make sure you adjust the dose. Some people find if they use one full capful, it may be too strong and they find they cannot have good control. Accident may happen. So it's better to start with a small dose, like quarter or half capful, instead of the full capful of Restore-Lax or Laxaday. So important to pay attention to our digestion. If after a walk, after a meal will help digestion, or if the symptoms of bloating is still bothersome, or you never feel hungry, may also indicate the motility is very slow with the bowel. So some doctor may consider using domperidone before lunch or supper to enhance the movement of the bowel. So again, we told Joe, set the alarm not to miss the dose for 8 o'clock, and also important to take levodopa on an empty stomach so that there's no congestion, right? So the pill will get to the small bowel much faster. So wait at least half to 1 hour before you have a meal. And if nausea is a problem, you may take the pill with slices of crackers of apple, just not with protein together. So never take it with a glass of milk. So always with water or juice. And if people have trouble swallowing the pill, if you need to crush the pill, just mix it with applesauce. So don't mix it with ice cream or pudding or yogurt. Applesauce is the best. Okay, so now we have our next client. His name is Hazel. He's 78 years old with Parkinson's, more than 15 years. She's been doing very well, except lately she noticed her body is more stiff and trouble walking before her next dose of levodopa in the afternoon. So the morning she's doing fine. She's taking levodopa 5 times a day, and she's also taking Rosagilin 1 milligram daily. So she's wondering if her pills are no longer working. So why does it happen? So as the disease progresses, our brain is making less and less dopamine. And as we know, levodopa is the very effective medication as it's getting to the brain and become dopamine. And the drug level goes up soon after you take a dose and the symptom goes away. However, our liver is responsible to get rid of medications. So after a few hours, the drug levels goes down and the symptoms return. So with close observation, you'll be able to see a pattern when levodopa begins to wear off. So as the disease progresses, we'll have less dopamine made and stored in our brain, and we begin to rely more on medication. So as you notice, the dose response curve become steeper, and the benefit of the duration of benefit becomes shorter. So therefore, a minor reduction in levodopa absorption, just like the case of Joe, where there's a delay absorption of transport of the pills to the small bowel, can causing delay or no on. And for more advanced disease, the therapeutic window become more narrow. And in Hazel's case, she experienced off before the usual dosing time. So some of the symptoms can be physical, such as harder to get up from chair, more stiff, and some patient may experience dystonia, so which is like the toes curl up, almost like a cramping, and it may also cause non-physical symptom. Some people may feel more anxious or find the thinking is not as clear. In some severe case, people may find harder to breathe or feel more irritable. Or some people may experience pain or sweating. So in terms of modification of levodopa, we may try to increase the dose, and increasing the dose would help the situation, unless someone have a tendency with dyskinesia, because higher dose can cause the peak dose dyskinesia. Or the other option is to take the medication more frequently, but it's not easy to manage beyond 4 doses a day, so increasing medication error. What about the option of control-release Sinemet? It is useful for prolonging the benefit, but the problem with the control-release tablet is the absorption is very unpredictable. So when you take it in the afternoon, you have no idea when it will work. Sometimes 2 hours, sometimes 3 hours is more unpredictable. So that's why we tend to use control release tablet for nighttime so that people can have benefit through the night. So for Hazel, the option we have will be the MAOT inhibitor. That's entacapone. So the reason we didn't choose MAOB inhibitor because Hazel is already on Rosagilin, and because of age and the risk for confusion, we don't want to use dopamine agonist. So the option we have will be entacapone. So entacapone is the medication that extends the benefit of levodopa by preventing the body to break down the medication. So it has to be taken with levodopa because entacapone alone has no benefit. The side effect usually just very mild nausea, but in some cases, patient may have profuse diarrhea. If that happens, entacapone has to be stopped. And it's a good advice to tell people not to bite the tablet because it can cause the orange brown color stain to teeth. And patient may also find bright orange urine color, but this is completely fine because it's not harmful when they find orange color in the urine. Entacapone is available as a combination tablet in the brand name of Stalevo, so make it easier. So for Hazel, we decide to consider adding entacapone. And so we explained to Hazel that her pills always work, and we just switch two of her levodopa dose to Stalevo, so that give her the additional benefit in the afternoon. So Hazel was doing well until she has to get her knee replacement. So she's scheduled to do her surgery, but before she go to the hospital, we give her some instruction. So for example, when she's on Rosagilin, basically all the MAOB inhibitor may have a warning of drug interaction. So when I talk about the MAOB inhibitors, I include the new drug, safinamide, that I'll be talking about that in more details. So MAOB inhibitors has a tendency to interact with different medication. So if Hazel go to the hospital, we need to tell her that here's the list of medication that your doctor should not give you while in hospital. So that includes Demerol for pain, or Tramadol, cough syrup for dry cough, the DM syrup, St. John's wort, that's antidepressant people can buy over the counter, or antibiotics, linezolid. So these can interact with the MAOB inhibitors. And the other thing we also want her is the schedule for her levodopa has to be fixed. So don't change it when she go to the hospital, because hospital have their own standard medication time, but that will not fit Hazel's day-to-day function. So it's important to tell the doctor that her levodopa has to be given the standard time according to her own schedule. So everybody's schedule is different. So in the hospital, the nurse will have to give her levodopa at 6:10 to 6:10. And also good to tell the staff that if her urine looks a little unusual, when the nurse is doing a urine sample, just to make sure she doesn't have bladder infection, and tell the nurse that don't worry, my urine looks orange brown, but this is perfectly normal, only because I'm on entacapone. So I thought this is a little good tips to mention. So Hazel admitted to hospital, and a whole bunch of drug that's not suitable for her because that can make her Parkinson's symptoms worse. So the middle column, all these medications for nausea should be avoided, and all the antipsychotic drugs should be avoided. The only safer alternative would be ondansetron or Grapho or ginger tablet. In terms of antipsychotic, so hopefully Hazel doesn't need any antipsychotic, but if she has delirium and she needs some antipsychotic, quetiapine will be the easiest one to use because clozapine require frequent blood tests to make sure this isn't any blood side effect called agranulocytosis. Okay, moving along, our last case is Tom. He experienced dyskinesia. He's only in his early 60s, so he's on levodopa, entacapone, also dopamine agonist, cinema-CR. He's also on amantadine because he has a lot of dyskinesia, so his body's swaying, but he also have a lot of ankle swelling and constipation. So amantadine is the drug to reduce dyskinesia, but it can cause insomnia if it's taken late in the evening. So the latest time to take amantadine would be late afternoon, not at bedtime. And other side effects including ankle swelling or the red skin blotches on legs, that's quite common. And also amantadine can cause confusion, dry mouth, blurred vision, constipation, trouble urinating. So amantadine is quite uh, problematic in terms of side effects, but we try to keep this drug as low as possible, only if dyskinesia is troublesome. So now we have this new medication. It's not mentioned in the treatment guideline because when we got together for the treatment guideline decision, sulfonamide wasn't released in the Canadian market yet. So I just included here so at least we have a complete picture for options that we have. This is a reversible MAOB inhibitor, so to keep dopamine in the brain longer, and it also reduces the abnormal glutamate release to reduce the dyskinesia. So it's like one drug, you have two benefits. The dose is once a day, and after a couple of weeks can be increased 100 milligram daily. You can take it with or without food. The side effects quite mild, mainly drowsiness or dizziness, and for the benefits of increasing on time without worsening dyskinesia. So the plan for Tom, since now we have sulfonamide, so we decide to stop his entacapone and use the new medication and make sure he has a multiple alarm or using his iPhone to set the alarm so he'll be reminded to take the pills on time. And if he's doing better, we can gradually reduce his amantadine so that we can reduce the side effects. So amantadine has to be reduced gradually, never stop suddenly, because our body need time to adjust. So amantadine has to be reduced gradually. And then he'll use a mobility diary to keep track of his symptoms. So highlighting the time he takes the pill, and then mark off the half an hour block when he has Parkinson's symptoms or dyskinesia with the D. So when he go back to see the doctor, we'll be able to see the improvement. So a whole bunch of resources that you can download. And here's the site, and you may find them helpful. And now we have some time for questions.